Hello, welcome to tonight's training on tendon injuries. Quite a common injury. Just wait for a few people to join and then we'll get going. Hi, we'll just wait for a couple more minutes for people to join. Fab, got a few of us here, so we'll start and anyone else who joins can catch up on the beginning bit after. Hi George. Fab, so tendon injuries. Today we're going to be going through what is a tendon to start with, because you're not going to know if it's injured if you don't know what it is. Then we're going to talk through sort of the stages of injury, how we get injured when it comes to a tendon injury, what we can do to prevent a tendon injury, and what happens once it's injured. So we're kind of going to be covering quite a lot, but hopefully won't take too long. So what is a tendon? Tendons attach bones to muscles. They're a connection point basically, and in some cases they will attach one set of bones to another set of bones as well, but for the most part we have bone, tendon, then the muscle. If we're looking at you see pictures of the skeleton with the muscles around it. The tendons are normally the white silvery bits, the muscles are the red bits, and the reason for that is tendons don't have a great blood supply, so that's why they're normally depicted in sort of a white silvery colour when we see them on a picture or an image. But a tendon is basically a flexible but inelastic cord of strong fibrous collagen tissue that attaches the muscle to the bone. And they're super important for the help of sort of transferring load across muscles, and also for helping to give us these sort of explosive movement power exercises that we like to do as well. But sadly they are often injured, and one of the reasons for that, as I mentioned with blood supply, is that blood supply isn't great with tendons. Therefore, when they do get injured, they tend to take a bit longer to get going again. Because if a tissue has got good blood supply, then that will bring with it oxygen, brings with it nutrients, and lots of good things that our tendons and muscles need for repair. So what is tendinopathy if we get sort of a tendinopathy or a tendon injury? So it's a breakdown of collagen within a tendon. And tendinopathy is more on a continuum than it is a specific diagnosis. So two people could have tendinopathy. One may present sort of as something being really inflamed, really sore, with a lot of pain, and other people might not have much pain at all, but maybe they just sort of wake up with some morning stiffness. And today's live, we're mainly going to be covering tendinopathies rather than tears to tendons, but we will speak a little bit about both. So a tendon tear will typically happen if you're doing something quite suddenly, and then you might maybe be pushing off or kicking, something like that, sort of pushing off to run, and that's when we might suddenly get a tear in the tendon, or quite often it's at the muscular tendinous junction, so that's where the muscle meets the tendon. It can be that bit there. We can, in really unfortunate cases as well, get a tendon rupture, and this can be where the tendon completely snaps, or it can be where the tendon avulses, which means it pulls part of the bone off with it and comes away. So we do quite commonly see those kind of injuries as well. Quite often with tendon ruptures, although that person may not have been complaining of any pain in that area before, so a typical tendon rupture would be like an Achilles rupture, which you might have heard of. People might not have been complaining of pain beforehand, but there could actually be some tissue in that tendon that isn't as healthy as we'd like it to be, but they have not noticed the pain, and then they go on to rupture it. So when we're looking at tendinopathies, which is what we're mainly focusing on today, there are three stages of that. And our first stage is a reactive tendon. So with our reactive tendon, it generally occurs in response to load. So this would be doing something more than usual, doing something longer than usual, harder than usual, changing footwear, changing surface, if we're running, for example. any of those things could potentially bring up a reactive tendon. It could even be something as small as you're a super fit, active person, you go to the gym all the time, you run all the time, and then you go away for 10 days on holiday, you sit around, you eat, you probably drink, you don't move too much, and then you come home and think, oh, I need to get rid of some of this holiday weight that I've gained, I'm going to go for a run. And even just doing that, where you've had 10 days of sort of relative rest compared to normal, that in itself can lead to a tendon that becomes quite reactive. With this reactive tendon, we will often notice that we get quite a bit of pain at the time. People might say that they feel that there's inflammation there, but actually it's non-inflammatory proliferation, and proliferation just means an increase in the amount of something. So we get a cell response in the area and in the tendon matrix itself, so the things that make up the tendon. And this increase in cell and tendon matrix, that actually increases the cross-sectional area of the tendon. So if your tendon is normally this big, that sort of increase in cellular activity could increase it to that size. And with that, it kind of helps distribute the loads better across the tendon in the short term. And it sort of helps with the stress that has been placed on that tendon. And the changes to the tendon at this point are very much reversible. What we have in this stage here, where it is reactive, is a chance to go back to having a nice healthy tendon. But what we typically see in clinic, and I see this a lot, is we'll take the Achilles as an example, so, back of your calf, sort of up above your heel. Someone will notice that their Achilles feels a little bit sore. They're like, oh yeah, it has been a bit sore after I run, doesn't feel terribly comfortable. Maybe it's not that bad, so I'm just going to keep running through it. And they continue to go for runs, keep going longer and harder, and then we end up in the next stage, which is tendon disrepair. The reason people often push tendon injuries more than muscle injuries is, with a muscle injury, you're generally reminded quite early on that you've got pain, because if your quad, for example, so our thigh muscle on the front, is sore and we go to kick a ball, straight away that pain is going to kick at you and you think, oh, that's not very nice, this hurts, and they're not going to continue. With tendon injuries, what typically happens is they might be sore before we do something, and they're typically very sore in the mornings, but then as soon as we start running around and we're warmed up, we often don't then get much pain. The pain then comes on afterwards, and so typically patients will present to us as physios and say, well, it's all right when I run. I'm like, okay, what's it like after? Oh, well, it hurts for 3 days afterwards. I can barely walk, can't sit on the toilet, can't get out of bed. And it's actually this after effect. So that's why people often carry on with their activities, because it doesn't hurt them at the time, it's more after. So in that reactive stage, what we want to be doing as physiotherapists is managing load, but we'll talk a bit more about that in a bit. So our next stage of a tendinopathy or a tendon injury is tendon disrepair. And this is a failed attempt at tendon healing. So with chronic overloading of the tendon, there is a continued production of cells in the area and in the tendon. That then results in the extracellular matrix, which is what makes up the tendon, basically becoming very disorganized. And that is not what we want. So some of the changes in this stage are reversible, but not all. And if you were to look at a tendon in this stage on an MRI, it can sometimes look like it's got holes in as well. Not that it necessarily does, but that is kind of what it looks like. And what we have happen when we have an injury at the tendon is collagen tries to lay down. So it's going, like this on top of each other, trying to make a really nice scar. A bit like if you've had a scab on your arm or your hand, you can kind of see it forming over a couple of days, and it gets bigger and bigger and eventually kind of drops off. But with our muscles and our tendons and that kind of thing, the collagen will lay down. If it's not been able to heal effectively, often this is because the collagen has laid down quite haphazardly. So we want the collagen to lay down nice and neatly. If this is the line of tension of our Achilles, though I suppose it runs vertically, we want it to be like that. What we don't want is to have mishmash of collagen fibre, because that will then lead to a really bad scar, often lead to shortening and pain, and scar tissue is quite engulfing of the area as well. And then we end up in this tendon disrepair stage where we're typically still getting pain, and often worse pain, and it's then harder to get the tendon back to normal as well. And so this stresses the importance of getting on top of these tendon injuries early so that we don't leave it to get to this disrepair stage. So our final stage of sort of tendinopathy is degeneration. And this is characterised by cell apoptosis and an extensive matrix disorganisation. So similar to what we were saying before, but basically worse. And that is due to chronic overloading. And apoptosis basically means organised cell death. So the cells in that area are actually dying. Doesn't mean you're not going to have a tendon at all. It just means that we're not going to have a great tendon there. And there's also neovascularization. So that is an increase in like little blood cells and nerves in that area. And that then can lead to more pain down the line as well. And these changes to the tendon will often stay with people. They might improve, but they're very rarely going to go back to having like a perfect tendon again. And it's interesting that at any stage of tendinopathy, you can get pain. And some people will have it really badly in one stage while someone else doesn't, but not everyone will. So therefore, pain management is actually quite important across the whole spectrum of tendon injuries. So when we're looking at our reactive tendons, that you remember we spoke about earlier, they're the ones that you do something for a bit longer than usual. You'll often see our primary treatment approach for these is load management. Appropriate load management will allow the tendon to adapt and to the acute stresses around it, and it will limit the progression of the tendon to the disrepair and the degenerative stage. So by load management, what I mean is if you, for example, using the example I used earlier of coming back from holiday, say you come back from holiday and in that first week back, you have run 20 kilometres, maybe you've done 4 5Ks, maybe you've done 1 10K, 2 5Ks, whatever you've done, and that has flared up your Achilles and made it sore. You can come and see me. I will then assess, how bad is this? How reactive is this? And I may say to you, okay, I think we need to rest for the next week. Or I might say, okay, you did 20K last week. Let's go just for 5 this week. So 25% of the previous load. But that will depend person to person. Commonly, I'll say, okay, we're going to rest this week from sort of running or anything that's really aggravating the tendons. So if you're feeling pain in anything, we're going to rest from there. And then I'll say, right, next week, we're then going to gradually increase any of those exercises or movements that are aggravating. So say it's running, I'll go, okay, next week, we're just going to stick at 5K across the whole week or 10K across the whole week, whatever I feel is appropriate. And we'll go from there. And the reason for that is I can then let the tendon settle down. We're not putting loads of stress on it, so we're not going to have to cause loads of collagen fibres to lay down and potentially lay down haphazardly. We're just letting it chill out, but then we do need to start stressing the tendon again so that it doesn't get worse, is what we need to do. And then when we're looking at our sort of disrepair and our degenerative stages, it's particularly important in those ones to actually be exercising more. And the reason for that is tendons need load going through. Something that I really commonly see here is, okay, my Achilles has been quite sore, so I decided to have a break from running. So I stopped running for 3 or 4 weeks and I went back to running and it was just as bad. In fact, it was worse than before. And I'm like, oh, okay, that's not a surprise to me, because tendons aren't going to get better with rest. They get better with loading, they get better with exercise. So we'll speak a bit more about that in a bit as well. But adjunct therapies that we can use, you can look at things like NSAIDs, so that would be like your ibuprofen, your paracetamols, just to help with a bit of pain management. Some research does show that corticosteroid injections in the very early stage can be quite good, and the reason for that is they limit the cell's ability to be super active. So when we get that proliferation where the cells are all going nuts, we can calm that down with a corticosteroid, but generally we will try and avoid doing this. Most of the time we'll try and just get people to manage their load effectively, and that settles it down. I don't think I've ever seen someone have a corticosteroid injection that early on in a tendon injury, but this is what the research said that I was reading. We can also use a bit of manual therapy with instrument-assisted soft tissue massage as well. So if those of you that come into clinic, you might have seen my silver tool. That's why I use that, particularly if you've got kind of any kind of tendon issue as well. And the reason for that is we're just trying to sort of reduce the tightness, reduce the load that's going across. And previously, we used to think that we were breaking up the scar tissue formation, and that's why we were doing it. And actually, a lot of the research has said that we can't put enough force in to deform the tissues enough to actually be stopping the scar tissue, which I thought was quite interesting. But instead, the reason that sort of our manual therapy techniques, or our massage and our instrument assisted stuff works, is because it really helps the mechanoreceptors. And so basically that helps them modulate the pain and alter the tone of the tissues as well. So then if someone's not feeling as much pain, that means that they're more likely to be able to do their rehab exercises, and they're going to get better a bit quicker, and they're not going to be as aggravated. And that's the thing with tendon injuries. I don't just want you out of pain, I want you functionally better, so that one, this doesn't happen again, and two, we're not going to go on to risk a tendon rupture or something like that, because that would not be good. So in lots of studies that have looked at tendon injuries from our Achilles and also from our quadriceps and patellar tendons, it was really interesting to see that anyone that had a tendon injury that side was weaker. And is this a chicken or egg situation? Was that side weaker and therefore it got a tendon injury? Or has it got a tendon injury and therefore it's now weaker? The other interesting thing about these studies was other measures outside of strength, so things like vertical jump height, so how high can you jump, and horizontal jump height, how high can you jump across the floor, actually remain the same. So it tells me that your body is compensating for that damage that you've got at that tendon, and perhaps actually in that case that weakness has been there for a while and potentially caused the tendon injury. So making sure that we've got good strength on both sides, even if it is our non-dominant side or our weaker side, I think is very important for helping prevent tendon injuries. And so that's the kind of things that we want to be looking at. When it comes to exercising tendons, well, for our sort of management of tendon injuries, there's two different schools of thought here, and I personally think that both are really effective. So our first one is eccentric loading. So eccentric muscle contraction would be, say if we're using my biceps, if I'm holding a weight in this hand, I'm slowly extending it out, I'm lengthening the bicep, but I'm also tensing that muscle and contracting that muscle at the same time. So that would be an example of an eccentric contraction. And if we're using our Achilles as an example, that would be if we're standing on top of a step and we're pointing our toes and we drop our heels down below the step, keeping the balls of our feet on the step. That is the eccentric part. And same thing, if you've been looking at our Instagram page recently, we've been putting up a few different tendon exercises, and one of them was for sort of forearm, for elbow tendinopathies. Again, going nice and slow down and coming up. That is an example of eccentric loading. And the reason that this is so effective is that we can get quite a lot of stimulation through the tendon when we're working eccentrically, because it's quite hard for the tendon to do. And with our muscles, we can get good stimulation if we've got a damaged muscle working at about 30% of someone's one repetition max. So if we know, for example, on a leg extension, our right quadricep can do 100 kilos, let's just say for easy maths. We know that if we put them at 30 kilos, they're going to be able to still get changes and adaptations in that muscle. But tendons don't work like that. Tendons need a lot more. They actually need nearer 70% of load going through them in order to make significant changes to that tendon to get progress. So if we're working eccentrically, we can essentially make the tendon work a little bit harder without having to load it up so much. So we could do something like for our Achilles, 3 sets of 15 with straight knee and 3 sets with bent knee. Calf raises off of a step, and that's called an Alfredson protocol, and you can do that twice a day, and that's quite effective. And that's something really easy that you can do at home, just really slowly lowering down, coming up as quickly as you would like. And you can start that on 2 legs initially, then you could move to single leg, you can move to weighted, whatever you kind of got available to you. But the other method that we have is something called heavy slow resistance. Now, I think this is really effective for the patients that I have that are, are gym goers who really don't want to be told that they can't go to the gym anymore and there's certain things that they can't do. So in this example, we'll take a quadriceps or a patellar tendinopathy. So typically we've got our patella here, our patellar tendon goes down there, and then above that, above our kneecap, we've got our quadriceps tendon. And for those that have pain here, often squatting will cause pain. And one of the reasons for that is you're compressing the tendon as you lower down. But the other reason is as our muscles are changing from eccentric to concentric, so that would be in a squat, my quadriceps as I'm going down are working eccentrically, they're lengthening, but I'm tensing them. They're working concentrically when I'm coming up because I'm shortening them, but I'm contracting them. But the changeover phase is called an amortization phase. And what is happening here, our muscles basically just been storing energy and it's kind of coming out to explode back up again. But that changeover, often if it happens quickly for those with injuries to tendons, can be quite painful. So often I'll say to people, okay, you still want to squat because you like going to the gym, you like having big strong legs, fair enough. What we're going to do is change your squat slightly. So maybe they're trying to do higher repetitions at the moment and we're going to change it to something heavier, or maybe they're already doing heavy ones. So I say to them, we're going to do 2 things, or 3 things in some case. Thing 1 is putting a box there. And by putting a box there, what I'm doing is slowing down that eccentric to concentric phase. And with a box squat, what I say to people, and this is from one of my friends, Charlie, I'm sure he'll watch this later, you're kissing the box with your bottom. So what we sometimes see people doing is they're squatting down, they get to the seat or the box and they just completely relax and they flop down. We don't want to do that. We want to get to the box, just touch the box and come straight back up again. So we're just, for a very small second, touching the box, slowing that amortization phase down before we come back up again. As well as limiting depth, which sometimes we have to do. Like I said, tendons aren't a big fan of compression, which is why we often won't use loads of stretching when it comes to their management. We might suggest foam rolling instead for the actual muscle, but not so much for the tendon. But yeah, we're slowing down that phase and we're also potentially reducing their depth slightly if we feel like that's necessary. The second thing that we're doing is we're saying to them, we're going to go down on that squat really slowly. And that might be 3, 5, 7 seconds, whatever you feel like is appropriate for that person. So we're going to slowly lower down and then we're going to come up as quickly as you would like. And what we're doing there is we're slowing down the eccentric phase to put the muscles under more tension, and then we're coming up. The third thing I will do is change their repetitions. So if they're already doing quite high reps, they're now going to start doing lower reps at a heavier weight and slower. And the reason for this is we're then getting that 70% mark for the tendon whilst lifting heavy. And a lot of your patients, well, a lot of our patients that go to the gym a lot are going to love you for it because they're like, oh, I can still squat, I can still do everything, I just need to adapt what I'm doing. And that's probably one of my biggest mottos in clinic is I don't want you stopping what you're doing, I want you adapting whilst you're injured, and then we can go back to what you were doing before. Because most people that like to train and exercise don't want to be told that they can't do it. In certain circumstances, you know, stress fractures and that kind of thing, people have to take a break. But where we can, we'll always adapt instead. So that's one of the things that we'll do. And with the research into heavy slow resistance or into eccentric, they've both been shown to be as effective as one another after 12 months. So when you're looking at people that have tendon injuries at 12 months time, they've all got the same results regardless of whether they did heavy slow resistance or they did eccentric exercises. But there has been some research to show that heavy slow resistance beats eccentric in the short phase. So in the short run, they get people out of pain a little bit faster. But not everyone, it's not going to be appropriate for everyone to do heavy slow resistance. Perhaps you've got someone that runs a lot but doesn't really do any strength training. It would be a bit unfair to them be like, right, we're going to put loads of weight on even though you're not used to doing this. And also based on equipment and what people have got at home. So if someone's got a quadricep tendinopathy, it's probably not going to be a super appropriate for me to say, okay, I want you doing heavy squats because they don't have anything at home. Maybe they don't want to join a gym. Maybe they can't afford to. Whereas I might say, okay, well, we can do wall sits because you've probably got a wall at home. So sometimes you just got to pick it based on the patient in front of you and what you're able to do. But they're the 2 techniques that we tend to use to help with tendon kind of injury management. As I said, don't tend to use stretching that much. Tendons don't like compression. Some people do find it's effective, so in that case they can carry on doing it, but for the most part I'm not going to make anyone do that. And then preventing tendon injuries. So this is mainly a case of managing load, so not increasing anything too soon. If you've got new footwear, don't go out for your longest run in a year. Go and do a slow run, think, okay, does this feel all right? Monitor how you feel. Again, if you're going to change surfaces, maybe you've been running on grass over the summer and now you're going to have to run on tarmac because the grass is really boggy. Again, don't go out for your longest run then. Build everything up nice and slowly. And same when you're lifting weights in the gym as well. If you're suddenly changing your repetitions, maybe you're doing things quite heavy and you're doing sets of 3 or 4 repetitions, and then you're going to do things for 10 to 15 because you're changing up your training, doing things slowly rather than being in a rush. The next thing is recognizing a reactive tendon, because I can't tell you how many times someone has come into me and been like, yeah, it's probably been like this for about 3 months now, actually. Like, to start with, it was just a bit sore. Then I sort of left it and now it's really bad. Recognizing it early on and coming to a physio straight away, or saying to yourself, right, I'm going to take a week off and then I'm going to slowly build back up again. Recognizing that reactive tendon straight away is going to be the key to preventing anything long term. And a good physio will be able to say to you, it's just a bit of overload, it's just reactive. We're just going to manage your load and see how you crack on. And the other thing is regular deload weeks. So for those of you that don't know what they are, it's something we often incorporate in the gym and when running as well. It's where you have a week every probably 4 to 6 weeks, sometimes a little bit longer, sometimes a little bit less, depending on you, where you just do less. So you're still training, but maybe you're running 50% of the distance that you did last week, or maybe you're in the gym and all of your lifts are set at 60% for 3 sets of 5 repetitions, rather than working at 80-90% for a fewer reps and that kind of thing. And the importance of them is they allow you time to rest, recover, recuperate, and prevent injuries. So me, myself, with my training, I tend to have a deload every 4 weeks, sometimes a bit longer, sometimes a bit less. There's been times this year where I've been immensely stressed with work and life and that kind of thing, and I've had to do it more regularly than that. And that's fine, because I think, I'd rather not have that the same intensity across my training for a month or 2 months and have gaps in between where I'm still exercising but not as hard, but I'm not getting injured, then push myself to the max at a time where I'm not getting much sleep, I'm really stressed, and then I go and get an injury, because that's just going to add to your problem. So whereas now, not quite as stressed, getting a bit more sleep, although my face probably doesn't look like that right now, so you can add them in as much or as little as you need to, is the other thing. So that's everything that I was going to mention on tendon injuries. If you have any questions, write them in the chat now. Here is your chance to ask me anything. If you think of any questions after this is finished, you can obviously DM me or write it as a comment on this video, because I'm sure if you're thinking it, then other people are too. But if you have a tendon injury or any other kind of injury, or you know anyone who does, then please feel free to message us on here, on Instagram, anything else that you would like, and we'll get back to you and let me know how you can help. Yeah, any questions? Fab. Don't think we've got any questions, but if anyone thinks of any, like I said, let me know. Thank you very much for joining tonight. Hope you have a lovely evening. Bye.